Uh, Good evening, everyone. At the outset, I would like to thank Vanathi ma'am for giving me this opportunity. It's really an honor for me to be a speaker in front of you. So this is my presentation on the last bastion of the infective perforation, that is therapeutic penetrating keratoplasty. So these are the various causes for the infection. I'm not going into the detail. I just would like to highlight my individual techniques. So the purpose of management is obviously the tectonic as well as the therapeutic, and these are the management options the previous speaker already discussed. So what should we use and when to use this is depends on the size of the perforation as well as activity of infection and availability of the donor tissue. So role of patch or therapeutic graft comes if it is very large or active infection, which will achieve tectonic as well as therapeutic purpose simultaneously without any disfigurement to the surface. So here I would like to present a video of a case where there is no other options presented before works. The only option left is the therapeutic patch graft. So it was a case of anterior staphyloma with normal B scan. So there is a good visual potential. So we decided to do therapeutic or more of the tectonic kind of graft here. So this is the video. First, I would like to do the peritomy. 360-degree peritomy was done, and after that, I never use the trephine in such cases because it is not fit usually. So I deflated it and separated the iris which is attached to the staphyloma very carefully. Should not, and I protect it with the help of forceps, blunt forceps. Now I excise this extra ledge of the tissue, and then I found that the iris is stuck inferiorly to the peripheral cornea. So I release it and release all the membranes from over it. I cut that atrophic iris tissue and then tried to did pupilloplasty here. So I managed to do a pupilloplasty here. This gives me benefit of less chance of the glaucoma, better photophobia tolerability, as well as the good shape of the pupil, and better IOL stability later on. So, and then I found while suturing, I found that there is a crescentic defect is there. So I just take an idea of the dimension and then I cut it from the peripheral rim with the help of trephine and fit it, incorporate it along with the sutures. So it will never compromise the shape of the tissue. So one can do this with this technique, and then we could achieve a good outcome, and we decided to do cataract later. This is again an individualized technique where we do a patch graft as routine. Here everything is similar, the technique of suturing is different. So I remove this necrotic material from there and then use trephine to outline the melted out tissue and excise with the curved one scissor, and then I took this peripheral rim for the patch graft harvesting. I marked the graft because these are the smaller graft and may disoriented while suturing. So I put this graft, and the suturing technique is different here. I first take a suture in the host and then from the graft and then again with the host. So instead of putting two sutures opposite to each other, I use a single suture from the host, then graft to again then host. So this is actually sandwiching that graft in between the edges of the defect. So and at the same time we need less number of the sutures here. You can see that usually we use at least 8 sutures, but here we can use only 4 sutures. So these are the 4 sutures are good enough to achieve a good tectonic stability and good sealing effect. So this technique we give the name the suture across technique. So after putting these 4 sutures across the graft, we bury all the sutures, and then we did synegalysis and then wash the anterior chamber. And we get good tightening. And you can see how stable is the wound and what a sealing of the defect. There is no leaking at all. So this is my preferred technique. Then again, madam already talked about the stenciling. This is our technique, and it works very well with my hand. I first excised, did peritomy, and then did cauterization, then mark the outline of the defect and put a transparent sheet over it. Now we only scratch along with the markings, not actually pricking the markings. We just make scratches. It will be visible, and then apply it on the this mounted cornea, and do apply this ink along with it, and you will get a sometimes smudging of dye is there, but you will get an idea of that. So first we do a partial thickness cut, and then we do a full thickness cut. Otherwise it become very flaccid. And then we resected out this diseased tissue, the necrotic cornea all around, as per the markings, and then we fit the tissue and secured it with 10 nylon interrupted sutures. And this is the post-op picture. And this is again a very individualized technique. We recently used this. There is a fistula with the continuous oozing through it. And though there is no visual potential, but we decided to seal it because there is risk of infection and prolonged hypotony. So here what we did, as you can see, the oozing is there. So we just tried to get the thickness of the tissue, and we marked a rectangular shape, and then we did a lamellar dissection over here. So this is lamellar, anterior lamella we prepared all over the markings with the help of crescent knife. This is otherwise end stage eye. So we just rotate it just like what we do. Okay, so just we rotate that graft, just like what we do to seal our container of pepper and salt pepper. We just rotate it and it seals. So we just did. This is better in end stage eye like Steven Johnson and other eyes. So this can work. I very recently did this technique and secured with this partially overlay suture. And it secured well. I demonstrated there is no oozing, no leaking. As you can see, there is no oozing at all. It's secured very well. So this works very well in end stage eyes like Steven Johnson and very diseased ocular surface, because the same autologous tissue is there.
Very good.
So
absolutely. Yes. So you don't have to place an amniotic also, which is again extraneous tissue. Yes.
Visual potential, but we need to seal that perforation. So this can be done.
Yeah.
So this is again a therapeutic. We decided to do. This is actually a decimeter seal, as you can see. Okay, finish.
Yeah.
Okay, so my take-home message is there are so many options for management of perforations. We should consider the size, infection activity, and availability of donor tissue for choosing options. The page grafts best for the large perforations and active infections solve the therapeutic and tectonic purpose simultaneously. Thank you.
Excellent videos. Thank you so much. Just one question for everybody present here. What is the exact plastic sheet that you use for your, because like you mentioned, the contour of that.
We use the wrapper of this 10 nylon sutures. That is transparent on one side, and other side it is opaque.
Okay.
So we use that sheet only. We actually need very small sheet, not a big one. So we can use that wrapper
of the 10
wrapper of the 10 nylon suture.
That is already sterilized.
Yeah, already sterilized, sir.
Good.
Yes.